Welcome, everyone. We just hang on for a few more minutes to wait for a few more participants, and we'll start in 2 minutes' time. So settle yourselves down, grab a cup of tea. Welcome, everyone. My name's Ines Rio. I'm from the GP Liaison Unit at the Royal Women's Hospital, and I can see some names there that I recognise. So welcome on this beautiful, almost spring day that we've had in Melbourne. Today we have a webinar session on cervical and breast cancer risk-based screening and management. I'd like to start off by actually acknowledging that wherever we are, we're meeting on the lands of our First Nations people and pay our respects, past, present and emerging. For me, I'm standing on the land of the Wurundjeri people of the Kulin Nation. I'd also like to thank the crew at Northwestern Melbourne Primary Health Network, in case I forget at the end. So that's Yvonne and Eliza for organising this evening and organising us. And also like to thank Emily Wilson from the GP Liaison Unit for again organising this session. So a little bit of housekeeping. All attendees are muted. There's a chat box. Feel free to chat. But there's also a Q&A box. So if you've got questions, if you could put them in the Q&A section. And what I'll do at the end of both Bruce's and David's talk is we'll have 10 or 15 minutes and I'll ask sort of thematic questions from the Q&A. The session's being recorded. You'll receive a link to the recording and also a copy of the slides post-session. The recording will also go up on the Royal Women's Hospital website and the Northwestern Melbourne Primary Health Network website. Please ensure that you join the session using the name you've registered with so that the PHM can mark off your attendance. And that's how you do it. Yeah. So we have two speakers this evening, and thank you very much to both of them. They're both heads of unit at the Royal Women's Hospital, deeply respected and run fantastic units. So David Reid is an experienced surgical gynaecologist who's a consultant and the lead for dysplasia and familial cancer services at the Women's. He's also an honorary senior lecturer at the Department of Obstetrics and Gynaecology at the University of Melbourne, an honorary consultant to the Familial Cancer Clinic at the Royal Melbourne. Professor Bruce Mann is a specialist breast surgeon. He's Professor of Surgery at the University of Melbourne and Director of the Breast Service, which runs both across the Royal Melbourne and Royal Women's, and he's Director of the Breast Tumour Stream for the Victorian Comprehensive Cancer Centre. His particular interest is in optimising treatment for those women with early breast cancer. So just a few save the dates. We have at the Women's 2 other CPD events coming up. One's on perinatal mental health. They're both webinars, and that's hosted by us as the lead in conjunction with PANDA and also the Parent Infant Research Institute. And we have our usual annual series of shared maternity care workshops, and that will be on Tuesday the 8th and the 15th, and they'll both be in our newsletters and also Northwestern Melbourne Primary Health Network. The shared maternity care workshops are the usual collaborative workshops, in this case led by the Women's, but also with the Mercy, Northern and Western. So our GP newsletter, which we get great feedback from, so please feel free to to subscribe to our GP news. There's more information there, or else if you pop in, if you're having any difficulty, if you email me. Thank you. So just a little reminder of health pathways. I think most GPs in northwestern Melbourne and around Victoria know about health pathways, but to let you know that there are particular health pathways that have been individualised for both cervical and for breast cancer. As you know, they're developed by clinicians, and there are desktop tools that is free, where you can actually work out both what investigations you might want to use in a particular circumstance, what red flags there are, what referral options there are locally. Thank you. Bruce is driving this. So again, we have a whole section on women's health that have been individualised to our area, including on cervical screening and breast issues. Thank you. So there's some of the areas that we have. And as I said, it's free, but do register so that you develop, get a username and password, and we can work out who's using what and what's useful and what we need to develop. And there's a feedback option for a quality improvement cycle too. So breast cancer screening, over to you, Bruce.
Thanks, Ines, and thanks everyone for the thanks for the invitation, and thanks for those who've registered. Apologies for not driving Ines's slides particularly well. What I'm going to do today is give an overview of, I'm really going to focus on breast cancer screening because it is a really important topic, and there's been quite a bit of controversy or discussion for a long time, and quite a few things have come up and will continue to come up. To set the scene, we should know that breast cancer outcomes, it's really a good news story. Here are some graphs showing an increasing incidence that's been happening for the last 30 years, probably related to lifestyle factors primarily. But at the same time as that increase in incidence, the mortality, the number of women dying from breast cancer has gone down, which actually means that the specific mortality per case has gone down dramatically. We know this has happened for two reasons. One is the development and implementation of better systemic therapies, various chemotherapies and drugs. But a major part of it is the earlier diagnosis due to population-based screening. The story of population-based screening, it's just on 50 years since the first of the trials of screening was published. This is Philip Strax, radiologist from New York, was involved in a screening trial for the health insurance plan of the Greater New York. And basically what they showed in this trial in the 60s was that single view mammography was better than clinical examination in earlier diagnosis, leading to reduced mortality. There have been a number of trials since. Many of them are well known to those in breast cancer, but these are the trials, many of them from UK, some from Scandinavia, and some from Canada, that have been analysed again and again. And the summary of the effect of it on breast cancer mortality is that populations where there is screening, the mortality from breast cancer is reduced by 20% over populations where there is no screening. When I was a medical student and a trainee, it felt that was fairly settled knowledge. All of these trials, the last of them accrued patients in the mid-80s, but it became quite controversial with a review by a guy called Peter Goertz from Denmark, who did an analysis, and basically he concluded that most of those trials that I've shown were biased, and in the only unbiased trials that there was no benefit from mammographic screening. And it's sort of quite remarkable that the trials that he picked to say that they were unbiased was particularly these Canadian trials, which happened to be the ones that showed no benefit. And the trials where there was a lot of benefit, they were all judged to be unbiased. This got a lot of press, a lot of people got on board, and it led to the UK launching an independent review by Michael Marmot, who's an epidemiologist. He's into health equity. He had no involvement in screening research at all, and that was intentional. They did a review of all of the trials, and their conclusion, and I think this is data that we use, is that in a situation, this is the UK situation, where women 50 to 69 are invited to screen every 3 years, in the population where there is the invitation, there's a 20% mortality. What that means is for every 230 women invited to screen, 1 breast cancer death would be prevented. But that includes those who didn't accept the invitation. And when they looked at for every 180 women screened, and this is from trials in the early 70s and 80s, 1 breast cancer death would be prevented. This was meant to be definitive, and I think unbiased people would say that it is. But then on again and again, a different analysis is looked at. This was something from the conversation 7 years ago. It resurfaced just last year, and they said that it depends which the research, and they commented on this Canadian trial. And I just want to show it's a sign of how data can be used in a mischievous manner. This was the paper. It was the 25-year follow-up of that trial, published in the BMJ, one of the most the top journals in the world. Tony Miller and Stephen Narrod are very prominent academics. Their conclusion was that annual mammography in women 40 to 59 does not reduce mortality beyond that of physical examination alone. And it's really very interesting that when we just analysed the results here, the number of, this is the remarkable thing, cancers in the mammography arm. So mammography is about asymptomatic screening, but of the cancers, 454 were actually palpable. So they were not screen detected, they were palpable. And only a third of them were impalpable. And then when you had a look at the risk of dying from breast cancer, or when you looked at all of the features, the difference between the cancers in the control arm and the detected arm, they were really no different. And then when you looked at the likelihood that women would die from breast cancer in this palpable arm, they were actually greater than those in the control arm. The deaths in study arm, within the first year, a patient who has a screen detected cancer doesn't die from breast cancer in the first year or two, yet in the mammography arm, the rate of deaths in the first year was double that in the control arm. Very clearly a highly biased study, but the problem is that this biased study has been included in analysis after analysis. And so when yet again someone will quote this study because it was published in a prominent journal, we have a problem, because this really is misinformation. What do we know? The optimal care pathways recommend regular screening, and we know for certain that those who have either breast screening or private mammography have lower stage at diagnosis and better survival. So it's good, but screening is not perfect. There are issues. The one that gets a lot of press, and I will talk about it a bit, is that of overdiagnosis. The idea that a lot of the DCIS, the pre-cancer or the early cancers that are diagnosed, would never have become clinically apparent. And the bias in the in the field is actually observed, is evident here. Or is it a bias, or research is being done with a result in mind? Because here are the range of estimates of overdiagnosis in the published series, and it ranges from none to what we think is true, which is about 10%, way up to 50%, a suggestion that 50% of those cancers diagnosed would never have become clinically significant. A recent reanalysis, and this is what I advise to women I see, is that overdiagnosis the rate of it really does depend on age. When you have patients who are over 70 and certainly over 75, quite a bit of screen detected cancer would be overdiagnosed because of competing risks of mortality. But in women who are 50 and the screening age is really 50 to 70, the incidence of overdiagnosis is probably around about 10%. But the real issue with overdiagnosis is overtreatment of low-risk lesions. In medicine, a lot of what we do about early diagnosis and treatment, be that for breast cancer, cervical cancer, I suspect, and David could comment, but hypertension, hypercholesterolemia, a lot of the disease that we find and treat would never have become clinically significant, so could be called overdiagnosis. The problem is the treatment. And this is something that applies to all preventative medicine. So a lot of our research that I won't be talking about here is identifying those with early, so stage 0 and stage 1 cancer, who can be spared treatment beyond surgery. So spared the radiation, spared the adjuvant therapy. A quote from a radiologist from Germany who's done a lot: the solution to overtreatment is not underdiagnosis. So the idea that we shouldn't be looking for lesions that might be overdiagnosed because we might overtreat them, well, the answer is to not overtreat them. We did some, so I think this is quite reassuring that we're not hurting our patients. We recently published a series from something that the breast group of the College of Surgeons, breast surgeons, do. We submit all our data to what's called the breast quality audit, and we analysed the results from 10,000 patients diagnosed in 2018, half screen detected, half not, and we assessed whether those screen detected patients might have been overdiagnosed or not. So that's the low and intermediate grade pre-cancer, DCIS, and the small invasive cancers. And we looked at how much treatment all of those patients had. Our assessment was that 16% may have been overdiagnosed, possibly overdiagnosed, but in those who were possibly overdiagnosed, almost none got chemo, about 10% got radiation, 6% endocrine therapy, 2.2% mastectomy, and again, almost none got an axillary node dissection. And therefore, our conclusion was that this overdiagnosis rarely leads to extensive treatment. And so we can reassure ourselves and our patients who may ask about this, that so that the way we are practicing medicine, we are not extensively treating those who are overdiagnosed. And another way to look at it, which is also reassuring, is a series that we published from our patients managed at Royal Melbourne and the Women's. And we compared those who we had treated for breast cancer or DCIS at Royal Melbourne Women's, who were either participating in breast screen or not. And when we say participating in breast screen, we included those whose cancers were diagnosed in screening or who had an interval cancer, a cancer emerging through screening rounds. We looked at their treatment and when we just compared. And what we found, and this again is an argument to our patients that screening is worthwhile, that those who were diagnosed while part of a screening program, their cancers were less aggressive, less likely to be node positive. But importantly, the rate of mastectomy was halved, the rate of axillary dissection was halved, fewer had post-mastectomy radiation, and fewer had chemotherapy. And so, as well as the mortality benefit, what this shows is participating in screening for those who are destined, fate has it that a cancer is going to be diagnosed, can know that the amount of treatment we will recommend is roughly half. We're now following these patients for outcomes, and we suspect will show that there is a substantial survival benefit, but we haven't quite done the analysis, so I don't know that for sure. And this treatment, importantly, we had corrected for overdiagnosis. We said that if 22% were overdiagnosed, this is still the findings. It's really robust. So that is one of the issues. A real issue we have with screening is low participation rate. So it's all very well for me to show data that screening, is very useful, less treatment, better outcomes, but only 54% of Australian women who are in the target range, that's 50 to 74, are compliant with the 2-yearly screening. This is a bit misleading in that, some have screening 3-yearly, they would be judged non-compliant. Some have screening in private. However, a lot are not diagnosed, and we see that through clinic. A lot of women in the target range are not having screening. And I think that will take a whole of society, health system. General practitioner advice is the top reason that women screen. The second one is friends, peer pressure, public relations campaigns, but the role of primary care is essential. So that is one of our issues. The second issue we have, and I alluded to them before, are interval cancers, in that screening as delivered is not finding all cancers. And in Canada, who have a similar system to us, they found that about 23% of cancers in a screened population were interval cancer. These were nastier and mortality was higher. And so reducing them has to be a target. And one of the major issues with screening cancers with interval cancer is the issue of mammographic density. It's getting more press. It will continue to get more press. Mammographic density is something that's assessed on a mammogram. It's the proportion of white glandular tissue compared to grey fatty tissue. A cancer is a small white distortion. Seeing a small white distortion in that mammogram on the left is much easier than on the right. And we know that mammographic density reduces sensitivity of mammogram. And so the interval cancer rate is higher in a group with high mammographic density. And density is also a risk factor, which is being worked on. So what do we do about density? We've been aware of it for a long time. Breast Screen Australia has been aware of it for a long time. I was involved in a statement, the position statement, where about 10 years ago, where it was acknowledged, and the statement was that more research is needed before we know what to do about it. It's one of those very unsatisfactory statements, but it was accurate at the time. Some things have happened. An important trial came out of the Netherlands in 2019, so-called DENSE trial, that looked at supplemental screening in women with extremely dense breasts. This is the BIRADS D density. These were women who had D density, had a normal screening mammo, were invited, randomized trial, half were invited to MR. Of those who were invited, half of them had an MRI. And what it showed is that in the group who were invited, the interval cancer rate went from 5.0 per 1,000 in the invited group down to 0.8 in those who had MRI. And what that showed is that by doing this additional MR, it dramatically reduced the interval cancer rate by over 80%. That's not a survival benefit, but interval cancer rate is a very good biomarker or an intermediate endpoint for survival. And this is this is some of the data that we're working on in our attempts to update Breast Screen Australia that I'll mention shortly. Going through the other issues, the other real, what I call the real issues in screening, is actually cancer in younger women. Now, breast screen was introduced in those 50 to 69. It's been increased to 74. You can see that this is the age-specific incidence. It certainly gets more common in this group. When a screening program was introduced, it made sense to target the group most likely to have the disease. But this was introduced in the 90s, and there are a substantial number of women who are less than 50 who get breast cancer. Not so many less than 40, but we remember those who did. But this is not an insignificant group. Currently in Australia, they are eligible for screening if they go and register, but are not invited. And this group is more likely to have higher mammographic density, and therefore the screening that is offered through breast screen, while it is useful, it is not as sensitive as other tests. And here, this is a series from Canada, and what it showed, they have a similar system to ours. This looked at the stage distribution at diagnosis according to age. What we really want to do is diagnose cancer at stage 1. And you can see there's the stage 1s in the women in screening age, much fewer in the younger women, and the number who are diagnosed at stage 3 in particular, these are the group who need extensive treatment, and despite extensive treatment, there is an uncomfortable mortality rate is higher in that group. So doing something about the early detection for women less than 50 is critical. So what's the future? I would say we need to address both real and imaginary concerns about screening. I've mentioned the real concerns. The imaginary concerns are its lack of effectiveness and the problem of overdiagnosis. I think they're addressing those are messaging, but the real concerns need to be addressed. And I think we have a growing problem, and I've said this in lots of fora, so not only here, that we do need to move towards some form of risk-adjusted screening so that we can find those at higher risk and use better technology for them. And it is important that our national program moves. It's not an emergency, but we do need to be addressing it, or else we do run the risk of devolving into a two-tier system where those who have the knowledge and the funds do one thing, and those who don't have to put up with something that is less than is possible. I'm not going to talk about it, but AI is a real area where in breast imaging is an area where AI is already having an effect in many places. It's been shown that having mammograms, one read by a radiologist and the other by the AI, is as good as what we do, which is 2 radiologists. And there is some really interesting work to suggest that an AI can look at a mammogram and predict future risk, seeing things that we don't know what it's seeing. It's very exciting. So it comes to the question, well, how do we move from our current system, which is good but could be improved? It's a system based on trials and technologies from the 60s to 80s, to one that's based on a better understanding of risk and newer screening technologies. That is the challenge. And it's something I've been working on for many years. It's work led by Carolyn Nixon, Kaz Nixon, epidemiologist, public health interested, who's done work on mammographic density for 25 years. And ROSA is a roadmap to optimising screening in Australia, funded by the federal government, and the money went via Cancer Council New South Wales Daffodil Centre. A lot of work, a lot of consultations, and we had the scoping phase, the technical phase, and a recommendations phase. We delivered our recommendations last year, which defines a roadmap to go from where we are to where we could be. I won't go through it all, but what we have ended up with is a 5-year program involving some trials to assess the feasibility, acceptability, and efficacy of a more risk-adjusted screening, where those at higher risk with high density would be offered something beyond standard mammography. And what we aim to do is implement a trial, model the outcomes, and that could then be the basis of it being scaled across the country. We were quite pleased when Mark Butler, in a media release late last year, talking about a review of Breast Screen Australia, he mentioned specifically that the ROSA work was going to be considered by this review. We believe that's happening. Now, that's all very good, but I know that the question is, what should we do in 2024? So,
can I just ask a question about that?
Sure.
Is there an element of genetic screening that's been considered as part of that sort of screening pathway from a population level?
Yeah, it's a great question. I believe that we will end up with, at some stage, including genetics. There's quite good information, data that looking at the SNP profile, the single nucleotide polymorphisms, we're able to separate the risk of breast cancer quite well. That's in breast cancer. It will apply in all sorts of disease. And I envisage a time that the way we will manage health maintenance would be to get people to do a blood test, say at 40, 35, I don't know, when an adult, and that will help define, identify the diseases that individual is at risk of and allow a more personalized screening. I'm sure that can happen. What we're looking at here, our view for breast screen, is that to implement that is huge. The implications of it is enormous. We believe that by simply looking at mammographic density and family history, we can identify 15% of the population who are at increased risk of breast cancer and increased risk of an interval cancer with standard mammography. And that's the group that we want to target for this trial of acceptability, feasibility, etc. And while we're doing that, we expect that the approach to determining risk, assessing individual risk, will evolve. But what we want to do is work out, well, what do you do once you've assessed the risk? It's rather than figure everything out perfectly and then think about what to do about it, what we need to do is start working out as a system what we can do about it. I think that makes sense. So what should we do in 2024? What am I doing? We do need to encourage breast screening. It is the best thing to do to minimize breast cancer mortality and morbidity, so it is less treatment. There is no question that for our patients, it is the right thing to do. When to start? I say, I think the data to start at 45 is quite strong. Someone who has no other risk factors, no real need to start then. Screening through Breast Screen Victoria, no cost to the individual, and we can be confident that it's good. There is a group who should consider something more. We have to keep it in perspective. The likelihood that any individual, either with high density or C density and a positive family history, is going to get a breast cancer in the next year or 5 years, it's always very small. So the likelihood that additional screening will find something for any individual really is small, and we don't want to overplay it. However, those who have these findings, if someone comes to me for advice, I do recommend adjunctive screening. After a discussion, what do I offer? A standard advice is getting the 3D mammogram and an ultrasound. It does have some additional detection, relatively low cost and high availability. The problem with ultrasound is that its sensitivity, its specificity is low, meaning that most of the additional things that are found on ultrasound will not be cancer, and it will cost a lot and cause a lot of anxiety and lead to a lot of referrals. And we have to be aware of it. So I say low cost to do it, but the implications can be higher cost. MRI is available, much higher sensitivity, but it has false positives. It's high cost. I think the out-of-pockets are $400 or $500. It varies. It is operator dependent, so there are centres whose MR expertise is greater than some others. We're doing a lot of work, and patients, those whose patients we're helping to look after will often have had a contrast enhanced mammography, much more like a standard mammogram, less expensive, and we do think that it's very promising and will play a role going forward. Currently, the capacity and the expertise is limited, but as
I've just lost you, Bruce. I'm not sure if anyone else has. Can everyone else hear Bruce?
No, I'm not able to hear him either.
So, Bruce, we've just lost your audio. I'll just ring him.
I think the computer audio is cut out both ways on his end.
Right, yeah. No one else can hear it either. Just cut out then.
hello, am I back?
You're back.
You're
You're
muted,
back,
Ines.
thank you.
I think
Thank
something
you.
happened, but you will have
No,
got it.
I'm just trying to wave you along. Great, thank you. So we lost the last two slides.
Well, basically, NBCF wants
left.
zero mortality. It's possible. A lot of effort's going into better therapies, but the way to do it is going to be to find disease at a very early stage, where almost everyone diagnosed at stage 0 and 1 will not die from breast cancer, and it is something that we as a whole healthcare community need to get behind. And happy to take some talk and
yeah, so great. That was so fantastic. And I wrote in the chat, I think that for me the take home message is over treatment is not a reason not to screen.
Oh.
And also the fact that GP advice was the #1 reason women go for screening. Now I've got a question that I think is really pertinent and I've never understood, which is the question about why isn't breast screening part of the National Cancer Screening Register? And it speaks to me as a woman who undertakes breast screening that there's quite tricky logistics in making appointments, getting results, the flow. I mean, that's very operational, but I think that there are really strong ways to actually implement improved screening, especially for marginalised groups.
What's the answer? I think it goes back to history. how it was implemented. It was the first screening program to be implemented, and it was implemented separately. And there's a few examples where things to do with breast have been done separate from the bigger system. Going back to your question about genetics, I think it would be a tragedy if individual diseases implement genetics where it is something that will apply to our whole health, not just cancer, but other things as well. So it's the answer is in the history of the programs. And once you've got a big program, it is hard to change.
Yeah, I think you're absolutely right, Bruce. And I think that, the question is that, getting that on the ground input in from providers, coalface providers like GPs and women, especially those that are most marginalised and don't turn up for the sort of meeting on a Tuesday afternoon, is really pivotal in how we change programs to actually meet.
I can make a bit of a comment that one of the things, there's a lot of pressure to disclose mammographic density. And it comes from women who have a mammogram. They're given the all clear. They present with an interval cancer. They then find out that they had high density, and that means that the mammogram was less sensitive. And they say, well, had I known, I would have had an MRI. And therefore, there is a great push, the right to know, we need to disclose. The problem is, as I mentioned, we don't know for sure what the best thing to do is. And this isn't provided in a programmatic manner. And you'll be pleased to hear that what is being suggested is that if a woman is found to be high density, she should talk to a doctor. And often her doctor, and maybe some online, what they do is they talk to their friendly breast surgeon who says, well, there's a range of options. And the question is, shall I send her to you? And, this is like, I can see some people, but this is not the way to run a national program. This is why we do need to update the program so we have something that is feasible at scale, and it will lead to better outcomes. And the reduced treatment costs should free funding. And I know I'm naive to think that it will, but it should.
But look, I've always admired your passion in that area, Bruce, and I feel absolutely right. This is a systems issue in lots of ways. It's about empowering care at the local level, but it's also a systems approach, especially for those most marginalised. And I think that those take-home messages, which is despite some of the fog to actually encourage breast screening, and actually the fact that there are, potential changes in the way we actually need to move forward with it, with regards to increasing sensitivity, specificity, and also a reach for the most marginalised and at risk is really important.
Yep. You couldn't put it better. The top bit there is the most important. Screening is good. Just because it could be better, just because it doesn't find everything, doesn't mean it's not worth doing. The T model Ford was good, and just because there wasn't an E-type Jag or a Tesla didn't mean it wasn't good. But what we need to do is move along and work for something better. And if primary care, if general practice the message can come there, we want something better, it will help those of us who are working hard on this.
And I think that, the move for general practice really for those listening over, and they know, but those listening over the next, 10 years is really going to be about personalised medicine.
Yep.
It's really going to be what your risk factors, be that genetic, lifestyle, biometric, actually, contribute to different risk factors, how we then screen for them and how we then actually modify. And much of that's going to happen at the primary care level, the coalface between general practitioner and person, and also actually between person before they hit the room, actually understanding what those risks are for themselves. Thank you very much, Bruce. That was fascinating, and thank you very much. And now I think I'm handing over to David Reid. Thank you very much. David Reid, who as I said, was head of dysplasia at the Royal Women's Hospital, and we've known each other for a very long time. And I often go to David for many questions, who will be talking about cervical screening. And there have been fairly significant changes, as you know, over the last 5 years. So over to you, David. Thank you. David, you're on mute. I still do it after 4 years, don't worry.
There we go. So I hope you can see my slides. Good. I'm going to be a dreadful pedant in, as we have known each other a very long time. Of course, my surname is German and it's Vrede, though of course it looks Reed to all Anglos. I've had the pleasure of being at the Royal Women's Hospital for 15 years, and during that time have been the lead clinician for the dysplasia unit, taking over for some very august people such as Michael Quinn, Jeff Tan, Rob Rome, and of course the recently deceased and much lamented loss of Bill Channon, who was really a founding father of colposcopy in the Women's in Melbourne. I'm going to be talking about the new program. I'm not going to look back to pap smears, but I am going to take some time to look at the lessons we learned in the first 2 to 3 years of HPV testing, and what's happening and where the future is going to take us. I have a few declarations of interest. Probably the most important one is that I'm chairman of the Australian Centre for the Prevention of Cervical Cancer, which you will all previously know as VCS Foundation, the organisation that performs at least 50 and at the moment more than 50% of Victoria's cervical screening tests. Going to look a little bit of HPV and cervical cancer screening just to draw a line under the change in December 2017, what the new paradigm has meant and the reality, and how we've had to make some adjustments, and what the future strategies and aims are. So you'll all know that HPV causes cervix cancer, and it is the cause in over 90% of cervix cancer worldwide. There are probably more than 60 genital types, of which 6 and 11 cause 90% of warts, and 16 and 18 cause 70% of cervical cancers worldwide. HPV is sexually transmitted. Infections are very common before the age of 30, and we usually resolve themselves without causing any risk for cancer. But 10% of persistent infections with potentially oncogenic types, of which we recognize about 15, will develop into high-grade dysplasia, and 1% per annum progress to cancer. So about 40% or less than 40% of all CIN2-3 would become a malignancy. We don't have a way of stratifying the risk if someone has an identified high-grade abnormality. We did a study with ACPCC, the women's and other organizations, looking at the types of HPV involved in cervix cancer in Australia, and the distribution is very much the same as it is globally, with nearly 70% being types 16 and 18, but another 20% being the 5 types that are now protected by the Gardasil 9 vaccination. These are the best estimates I can get. I've been looking for an update on this, but it hasn't come through. Well, we get about 900 plus cases of invasive cervix cancer per year in Australia, and about 240 deaths. We are seeing over 16,000 women with CIN2 plus, about nearly 1% of those who undergo screening. And the 5-year survival for invasive cancer across all stages is 73%. Between 1991 and 2010, the number of new cases of cervical cancer in women aged under 24 years was about 10 per year, though it varied between 4 and 18, and there were very few deaths. The numbers of cases now in the age of vaccination is significantly reduced. We're waiting to publish on that. It's one of the reasons why screening was moved to start at 25. In Australia, 70% plus of women with cervical cancer have not been screened or have missed screening tests, which is tragic. I've seen 2 cases like this in the last fortnight. This is what happened. Can you see my arrow here? I hope so. So this was the high incidence of cervix cancer, approximately equal to what it still is in Japan. And I'll talk about that if you're interested. And this is where we began opportunistic screening. So women were offered pap tests by some GPs and specialists. You can see that mortality was falling as treatment improved. This is when we introduced screening, and not surprisingly, there was an increase in the numbers of cancers detected, hopefully mostly early stage, and this dropped very rapidly to the early 2000s, but subsequently plateaued. The two reasons it plateaued were, one, as in breast screening, lack of engagement, but of course the problem with cervical cancer is the people who don't engage with screening are the ones most at risk. And also the actual sensitivity of the pap test, which for a single pap test to detect high-grade dysplasia was actually only about 70%. The vaccination program was introduced 2006 with the Gardasil 4 quadrivalent vaccine protecting against 1618 and genital warts. And that was offered as a 3-dose regimen to girls. We had a catch-up program from 2007 to 2009 for females aged 12 to 26. And that was done through schools, through further education and general practice. And these women are now over 40 years old. So Australia has a bigger vaccinated cohort of women than any other country per capita. School vaccination became usual, and a catch-up program was introduced, and for boys in 2013, 2014. This was to protect, add additional protection for women, but also to protect men who became men who had sex with men from HPV disease, particularly anal cancer. The vaccination in schools for boys and girls was usually at age 12 to 13. And we had an extended catch-up from 2017. And this was really to offer school-based vaccination for individuals whose parents had refused vaccination before the age of 16, though Gillick competency applies to the consent of vaccination in this group. We went to a 2-dose version of the Gardasil 9 vaccine in 2018, and we now have very strong evidence that in adolescents only 1 dose is required, and we have extended the routine catch-up to age 25. In terms of the license, the vaccine was always licensed between the ages of 9 and 45. And there was benefit to women up to the age of 45 in being vaccinated, though obviously not as significant as if they had the vaccine before they began their sexual lives. The recommendations that were accepted in 2014 and were fully funded in 2015 by the Abbott government were because pap tests were not producing any further reductions in incidence or mortality. And because of the introduction of the vaccine that would make screening by cytology much more complex. So a new test was introduced. We would look for 14 oncogenic types, but we would particularly individually look for 16 and 18. Anybody with 16 and 18 would have colposcopy, and other types would have a reflex cytology test, which would be the basis of triage. The screening interval could safely be increased to 5 years. In fact, it could probably be safely increased to 8 years and still be better than PAPS tests at 2 years. And the ages was extended from 25 to 74. Self-collection initially was introduced for never screened and underscreened women over the age of 30. And there was to be a national register that was eventually run by Telstra Health. You know this initial pathway probably very well. If you had HPV 16 or 18, you had reflex cytology, but regardless of that result, you had colposcopy. If you had non-16, 18, and one of the 12 viruses in this group, if you had a possible high grade, you came to colposcopy. Where if you had a negative or low grade, you had a repeat test in 12 months. And if that was positive, you came to colposcopy. It was anticipated in that second test for non-16, 18, more than 60% would be negative at the second test. I'm not going to go through this in detail. This is a slide for teaching young GPs and nurses who want to learn screening how to take the test. I'm sure you know this very well. These are the devices that can be used for collecting to go into liquid. The cervix brooms are very helpful. I don't find the broom on the right to be particularly helpful, and it is rather how shall I say, it causes quite a lot of tissue damage in the canal with bleeding. So our preference at the women's, when collecting a specimen for cytology, is to use the broom and then to get a sample from the brush. The simple use of the broom in screening has reduced the number of cases that have endocervical component to their cytology. That may be important in terms of recognizing sampling across the transformation zone, which is the area most at risk of dysplasia. This is from Melbourne Health, or Melbourne Path rather, with a clear indication about how you do the test. The one thing I find that people have sometimes missed is number 6 here. There are 2 lines on the vial for thin prep, and they are to be aligned when you close the vial. That ensures security and lack of leakage, but it also means the robot can open the vial. If you turn it more than that, the robot will struggle, and that causes some troubles at the laboratory. You know, there are new guidelines. Here they are, and they're available on the web through the Cancer Council Australia. They are very shortly to be updated, and I'll tell you about that. So what happened? So the last year of PAP screening, the Women's Hospital had 2,440 referrals. We had 1,500 first visits and 550 treatments. But by the first full year of HPV testing, we had 4,100 referrals, 2,200 first visits, and 660 treatments. And this was not unconnected to the fact that the hope that non-16/18 negative rates at second screening would be low was probably an overestimate. So we looked at our data from the onset of the new program through to the 30th of June 2020. We don't as yet have data beyond that, because that's when we implemented our new massive and superb electronic medical record that sucks in data, but is not terribly good at getting it out. Excuse me, one moment.
That can't hear you, David.
Sorry, my wife, who is the Director of Cancer Services at the Royal Women's Hospital in
I'm
Gynecology,
going to ask a question now.
just
I'm gonna take
arrived
that
home, and the dogs went off.
Get
I'm
in.
sorry about that.
I'm
Yeah,
going to
go
take
ahead.
I'm going to take this opportunity to ask a very GP question, which is many of us are actually going to a lot more self-screening at the moment, which I think
I'm going to get through to that.
I'll ask you later then.
Yeah, no. So this is what happened to us, and we looked at 4,500 women and what was going on in terms of detecting disease, and what we found was what we pretty much expected, that type 16 or 18 was 42% of our referrals, and that's because you know, a lot of these women had not yet been vaccinated, and all 16 and 18 it was detected comes into us. If the reflex cytology was reported to be high grade, we found the disease in nearly 90%. Interestingly, with non-16/18, which was you know, the remaining 58% of referrals, where it said high grade or possible high grade, about only 60% did we detect the SIN2 histologically, and where the reflex cytology was low grade or better, only 1 in 10 actually had high grade disease. Of women with type 3 transformation zone and no evidence of high grade disease, or on reflex cytology or colposcopy or any form of biopsy, we only detected SIN2 in 2.5%, which was interesting. Our positive predictive value for the group of colposcopists at the hospital was 70%, and that's pretty good, and aligns well with benchmarks for other hospitals with experienced colposcopists. But positive predictive value, we feel, may not be the best measure of colposcopic quality moving forward. As you know, after treatment, follow-up tests should be performed, and that was an HPV and cytology test, which was to be negative for both modalities of test in 2 consecutive samples before women returned to normal screening if they'd had squamous lesions. Unfortunately, I think that moving the follow-up from 6 months to 12 months did increase, in our experience, the FTA and DNA rate, which is a little bit alarming in terms of follow-up after treatment. There was a national review that was published in the BMJ in 2022, and that was 3.7 million women. This came through the National Cancer Screening Programme and the Daffodil Centre in Sydney, which is the home of C4, the NHMRC Centre for Cervical Control, the Cervical Cancer Control, of which I'm happy to be an AI. And this found that when we looked at the screening itself, type 16 and 18 in the population had really collapsed to 2%, and the other 12 types were about 6.5%. Colposcopy referral was initially 3.5%, but it was rising to over 6% of all repeat tests, and that was causing problems for public colposcopy clinics right across Australia. There were 450 cancers detected, nearly 1%, and interestingly 90 or 89 of those, 0.32%, were detected with HPV 16 or 18 positivity, but negative reflex cytology, demonstrating the superior sensitivity of HPV test for this disease. With non-16/18 positivity and less than or equal to low-grade cytology, 3.4% had SYN3 or higher, but only 0.2% had a cancer. However, this group represented 62% of all referrals. And this was causing all of these problems across colposcopy services. We were certainly suggesting that we needed to biopsy lesions more frequently in order to detect high-grade disease, which didn't always have the classic appearance. One of the things we think we've learnt from the program is that what we were all taught was the classic colposcopic appearance of SYN3 is actually HPV 16 disease. And with non-16/18 types, SYN2 and 3 histologically can have a different appearance at the colposcope. So our suspicion for high-grade disease has to become higher. Managing what we call type 3 transformation zones, where we cannot see the junction between the squamous and the glandular tissue, it was a particular problem. We do like the liberal use of estrogen locally before patients come to see us, and we have been using endocervical curettes, and we may be moving to such adjunctive technologies as dual stain, which looks for specific proteins by immunohistochemistry and is part of the COMPASS trial. I've certainly told people to avoid treating HPV. We've had some problems with that I'll allude to later. We very much advise people to review possible high-grade cytology. We have regular colposcopy meetings at the women's, and so do other units. For private practitioners, they're strongly encouraged to speak to their reporting cytologist. Anyway, you may now all recognize that this is the current pathway. And what we've said is that with non-16/18 disease, you can really run to 3 annual tests if you have low-grade or normal cytology before you come to colposcopy, or 2 tests 2 years apart. But there is a little proviso, there is a little get-out clause here after the second test for women over 50, for women who identify as Aboriginal or Torres Strait Islander, and for women who haven't had screening up to date. I also include in this group women who are immunocompromised. Self-collection using PCR-based assays is as accurate for the detection of SYN2 as a clinician-collected sample. This is an absolutely unambiguous result. And before a big education program began earlier this year, a significant proportion of general practitioners were suspicious that self-testing wasn't as sensitive as a clinician-collected sample. I want to reassure you that for detection of HPV DNA, it is an excellent test. If you look at this ROC plot here of sensitivity against specificity, by and large, you have to get to the left of the diagonal line to be considered a test that is useful. Breast screening won't nearly achieve the lines that you see here that are clinician and self-collected HPV tests. And these are the confidence envelopes around those tests. It's almost never seen that a screening test comes this high up in that corner of such a plot. And I do want to reassure everybody that these are simply superlative tests compared particularly with the PAP test.
Dave, now this is a good time for my question, which
Sure.
is I'm a complete convert to the self-test, and I think many of us are increasingly. But if you've actually had a self-test, if a patient's had a self-test and they get it non-16-18 and you're repeating it in a year, is it still okay to do a self-test? Because in those circumstances, I've been tentative and I haven't done one.
Look, I think it's a conversation you have with the patient. If they've had a non-16-18 positive test, they're going to have to come back for you for a cytology anyway. And they may say, you may say to them, well, next year, if we do one test, I can get the answer to both parts of it. But if you prefer the self-test, you can have the self-test again, understanding that you may yet again have to come back for cytology. I don't think they're hard and fast rules. But if a woman's experienced a self-test and then a cytology test, she may then also say, oh, well, I've had the cytology test. Yet I know what to expect. It wasn't as bad as I feared. Therefore, I'm quite happy to have a clinician-collected sample at the next point of screening.
Thank you.
So self-collection using PCR-based assays is accurate for the detection. We did a study between the Royal Women's Hospital and VCS called the SCOPE study. In fact, we've done SCOPE 2 since then. And we had 300 women in which they collected a sample and the clinicians collected a sample using the broom brush technique. And all paired samples were sent to VCS cytology. They were left at ambient temperature for 7 days prior to processing. But we've now demonstrated a stability of the test well over 14 days and even at very high temperatures, because DNA is a lovely stable molecule. What we saw was a strong correlation between self-testing and clinician-collected testing, with high levels of observed agreement and high kappa scores, except for slightly lower for any HPV or the other HPVs, but particularly for 16 or 18, the correlation was extremely high, and the sensitivity of the test was equally good, whether it was clinician or self-collected. There's a very strong preference amongst women for the self-collection test. It's easier, takes the fear out of it, and we have also seen that over 90 or nearly 92% of women who've had a self-test completed the follow-up testing within 180 days of the self-collection being done. So there's strong evidence that the self-test is sensitive, effective, and also acceptable to patients, or I should say people with a cervix. So self-testing was there from the beginning for a limited number of women. It became open to all from the 1st of July 2022. We do specify that it's all persons with a cervix, because transgender men should be screening for HPV. And everyone who was in the national program was given the choice to use a clinician-collected or a self-collected vaginal sample. By and large, the self-test is done in a healthcare setting, whether that's a practice or an outreach clinic. But in fact, it's perfectly possible for the patient to be given the instructions on the swab and take it home, consider what they want to do, take the test and bring it back to the place of practice. And that is now accepted. We have not, however, moved to the post-out self-test version, which is used obviously with bowel screening. By the middle of last year, 45% of all screening tests received at ACPCC were self-collected vaginal swabs. And I have to tell you, this year that has now approached nearly 55%. One little topic I want to talk about, which was probably not foreseen very well in the initial program, was the number of older women who would be found to be HPV positive. Pap test screening reduced cervix cancer really between the ages of 30 and 55, but we've always known that there was a bimodal distribution to this disease with an increasing incidence beyond the age of 70, and Pap test screening never suppressed that. In the women's, between those dates of 1st of January 2018 and 31st of July 2020, we saw 464 women aged 50 to 74 in the colposcopy clinic. 172 of those had non-16/18 HPV with 40% SIN2 rate, and 292 had 16 or 18 with less than 10% having SIN2. In fact, 73% had a reflex negative cytology, but of those 214 with negative cytology, 7 were found to have high-grade precancer at colposcopy, and 1 was found to have invasive disease. So overall, 54 women had SIN2, including 7 cancers, up to 2 years after the first colposcopy. And we detected nearly 90% of the high-grade disease at the first visit by excision or by finding possible high-grade or worse cytology. The positive predictive value of colposcopy in this group was low, not least because we had a high rate of type 3 transformation zones, over 50%. And with those type 3 transformation zones, 20 had SIN2, with 13 found at the first visit, including 3 cancers. So at our hospital, we encourage high rates of biopsy, endocervical curette, for all women coming in who've waited 3 months or do not have endocervical cells in their cytology or have a possible high-grade cytology in the reflex test. We recommend a broom and brush cytology in order to make sure we're sampling across the transformation zone. And we are very careful in the selection for excisional treatment in this age group. So we want proven high-grade disease or a high suspicion of high-grade disease because of cytology, and a significant number of these women are reviewed in our MDM with our pathology and cytology colleagues. There have been numerous stories of less experienced gynecologists excising the cervix for HPV-16 with no indication that there's high-grade disease. They've then been found to be HPV-16 persistently positive after the excision, and then have been offered hysterectomy. And then they've been offered another test as a test of cure and been found to have HPV-16 at the top of the vagina, which is the point at which they get referred to me. And the clinician often asks, what should I do? And my response, rather sarcastically, is to say, invent a time machine, go back to the time before you did the first excision and don't do it. And we're trying to get this information out to all gynecologists that they must not treat HPV with surgery. It is really going to lead them down a path of unhelpfulness, and they should be spending their time reassuring women who are carrying HPV at a low level, who do not have dysplasia, that they do not need treatment. Now, I think you may all be aware that in 2020, WHO Director General calls for countries to take action to help end the suffering caused by cervix cancer. What may not be known to you is that the biggest killer of women across the globe in reproductive ages is now cervix cancer, given the very successful WHO program to reduce maternal mortality at parturition. There'll be 600,000 cases of cervix cancer this year globally, and 250,000 to 300,000 women will die of the disease, many of them not only without treatment, but without palliation. The aim is that 90% of girls should be fully vaccinated with the vaccine by 15. 70% of women are screened with a high precision test, at 35 and 45, and 90% of women with identified cervix cancer receive appropriate treatment and care. And these are all minima. It was accepted in the Assembly in August 2020 in the middle of the pandemic. C4 in Sydney, Karen Canfell and Professor Marion Saville played a very prominent role in promoting the resolution. So this is quite a busy slide. Again, a publication from the C4 group. But what I want you to look at really are the blue and the purple lines. So if we just didn't really have vaccination, what we would see is a staggering increase in the number of pre-cancer treatments. If we're using HPV Gardasil 9 and then screening twice in a lifetime, we would follow the purple curve to reduce cervix cancer to almost vanishingly low levels, and the number of treatments being required for SIN2+ also reducing massively. Now, realistically, because we have a mixed population who are protected by Gardasil 4, Gardasil 9, we will probably fall somewhere between the red and the purple curves in terms of reduction of disease. But there is a very significant hope that Australia will be the first country to reach the first elimination target. In terms of elimination, there are targets. This is not about eradication as yet. So we have about 6 to 7 cases per 100,000 women per year in Australia. The first target is to get that below 4. The next target is then below 1. We are certainly hopeful to get the below 4 target before 2035 and to be the first country to achieve it. So, key messages. Australia's HPV testing program is an enormous success. We must maintain, if possible, improve current levels of screening and vaccination. And also hospitals need to be involved in screening more consistently. We know that significant numbers of immigrant women, their first contact with any kind of medical services in Australia is through antenatal care. And with the change in the way we do antenatal care and book patients, a pelvic examination, including speculum, has dropped off obstetrics at that stage of pregnancy, and women were not being offered screening. That is now going to be changed. They have a wonderful young and committed doctor at Monash who's made it happen, and we're making it happen at the Women's. We are on track to be the first country to achieve the WHO primary elimination target for cervix cancer. But an extra note we would add to that target is it's a target that needs to be met by all demographies. And therefore, particularly, we need to target Aboriginal Torres Strait Islander women who have consistently had 2 to 3 times the amount of cervix cancer that European Australians have had. And that also includes new refugees and recent immigrants. I want to reassure you all, self-testing is as sensitive as clinician-collected samples and is very popular with patients, as you'll see. Could you please prescribe Avestin cream for all women in menopause before testing and colposcopy? Now, that may not be necessary if they're doing a self-collect, but it would be. I don't know what's happened there.
It's very timely, because one of the questions was, what's the Avestin?
So I don't think you need to do it before a self-collect for an HPV test, but you might then want to, if they're positive for HPV and coming back for a reflex cytology, you might want to give them 2 to 4 weeks of Avestin cream before they have the cytology. And I please beg all general practitioners to encourage women to use Avestin between the time of a positive test and referral for colposcopy. It makes the colposcopy more comfortable, it makes the colposcopy easier to assess, and it makes any tests or cytology that we take at the time of colposcopy easier for the pathologists. I know that the data sheet in the Avestin packaging is appalling in terms of its risks. I would reassure you, and I have reassurance from my friends in menopause clinic, this is estriol, it's not estradiol, it's at 0.1%. It really works locally. The amount that's absorbed is absolutely tiny. The risks are minimal, and it makes such an enormous difference. Finally, there is a guideline revision going out for public consultation shortly. I can reveal a couple of the points that are going on. The test of cure for squamous abnormalities is to be 2 annual HPV tests. And that gives women the option of self-collection, which we hope will improve the follow-up after treatment. There will be changes to the follow-up of women with glandular precancers, which are rarer. And also we hope that we can make re-referral for women with persistent type 16 and or 18 HPV less frequent. That is, if women, and this refers to the menopausal age group, if women have had an HPV 16 positive test and they've come to, with negative cytology, they've come to us, we've said it's okay, and they get a test next year and it's HPV 16 positive, but low grade or less, they don't immediately need to come back to colposcopy. But if they have another test a year later that's positive, then they should come back. And hopefully that will stop this annual merry-go-round for those women who have persistent HPV disease. I am happy to talk a bit about that HPV persistent disease question in the question and answer session. We are just about to begin a trial of a new topical treatment to treat persistent HPV. It is a vaginal gel. It certainly isn't surgical treatment. And we'll have to wait some considerable time to see if that's helpful. But women with persistent HPV with no evidence of high-grade dysplasia should not be having operations. Just for your information, we're having the Eliminating Cervical Cancer Conference in Melbourne in November. This will be a very high-profile conference of our work, not just in Australia, but also across the region into Oceania and PNG, Myanmar, and collaborations with South Asia and into East Africa. So Australia is a world leader in cervical cancer screening prevention. WHO adopted strategy for elimination in 2020, and we are the second country in the world to have moved to HPV testing, which has produced significant challenges for colposcopists, which have been helped by the secondary change in guidelines. Self-collection for HPV DNA analysis is a tool to drive equity amongst disadvantaged and underscreened groups. The continuing vaccination program and recent changes to cervical cancer screening should see Australia as one of the first countries to reach that primary elimination target, but it has to be achieved for all groups. As a nation, as a rich nation, we have the ability and indeed the duty to work in partnership with colleagues throughout the Indo-Pacific region to eliminate cervix cancer, where rates of invasive disease may be 5 to 6 times what we see in Australia. This is the list of people I'm indebted to, worked with now or in the past, people who were involved in ASCCP, in the guideline creation, in research, and nurses and research nurses at our hospital.
Thank you, David.
There's some links which will come through for other information.
Right, and I think, as you said, cervical prevention, we were the first country that actually developed the HPV vaccine, the whole screening and the iterative development of that and management has been really, I think, down to a handful of people that have driven it, and you've been one of those people, David. And I think, as you've highlighted now, it's about, equity with a small group of people in Australia's subpopulation, people that are underscreened, people from ATSI population, call, people that are immunosuppressed, and also actually driving some equity changes and system changes in the, Pacific and Papua New Guinea areas that we can actually make substantial differences with. So thank you very much for your commitment and the talk. So I don't have any other questions. I think I'm going to get everyone home on time or back to their dinner on time. So just with the conclusion, you'll receive a post-session email within a week, which will include the slides and the resources and the certificate of attendance. The RACGP CPD hours will be uploaded within 30 days. Thank you to Yvonne, who's actually managed to work out who everyone is. So everyone should get their CPD statements. There's a series of further education sessions through Northwestern Melbourne Primary Health Network, and also the Royal Women's Hospital and the GP Liaison run a series as well. And I think that might be it. So look, thank you very much, David. I think Bruce has already gone off, and thank you to him. Once again, thank you to Yvonne, to Eliza, and to Emily, and thank you everyone for coming this evening. I hope it's been valuable. Thank you. Good evening.
Thank you so much, Jim. Bye-bye.